Hello guys. So today's topic is actually refractory rickets. But before going, because we had a good gap, I just wanted you to have a quick revision of what we did in the first class. That is vitamin D deficiency or a simple rickets that we spoke of. Okay. So in this class, what we did was we first went through the basic physiology of absorption of vitamin D, calcium, phosphorus. We also discussed about PTH. We also discussed about calcitonin. Correct. So all this we did. Then we found out when do we call it as vitamin D deficiency. And here we discussed that this vitamin D that is done is 25 hydroxy vitamin D. It's not calcitriol, but it is calcidiol, which is tested in the blood. Then we discussed about rickets. We just briefly went through this classification of rickets, and then we came to the presentation and head-to-toe examination in detail. So now why am I revising this? This presentation is nearly the same even in a refractory rickets case. Okay. So in head, we had few findings that we discussed in detail. Then we had CNS findings. Then we had chest findings. Then we had upper limb Harrison circles, upper limb, lower limb muscles, abdomen, pelvis, extremities. All of this we discussed in detail, correct? And then we even discussed the approach. How do we approach a child with rickets? Okay. So where we basically concentrated on nutritional deficiency and how to pick up that nutritional deficiency. What are the baseline investigations that we are supposed to do? 3 investigations compulsory: calcium, phosphorus, ALP, and vitamin D. And then we found out that in radiology is compulsory for all the cases, where we found that in radiology, we will pick up a lot of findings like cupping, splaying, fraying, all of that. Okay. And we also discussed why there is widening of the growth plate there. Briefly, we touched upon the difference between the scurvy and vitamin D deficiency, that is rickets. And we discussed about the difference, correct? So we were here in the last class where at this point, we have diagnosed a vitamin D deficiency, rickets, and we are finding out how to treat it. So child with nutritional rickets, when it is symptomatic, like as in seizures, especially below 6 months, we give a IV calcium gluconate 1 to 2 ml per kg. Then we followed by maintenance of vitamin D and calcium phosphorus. Correct? If it is a asymptomatic hypocalcemia, wherein there are only limb deformities, that is your genu valgum, verum, all of that, widened wrist, all of that, then depending on the age, we have different dosage system. Now, previously something called as STOS regimen was followed, wherein at a stretch we'll give 6 lakh international units IM for the child. Now, this is contraindicated, especially below 3 months. But above 3 months, if we suspect that the patient might never turn up or not come for follow-up, we can still stick to STOS regimen. Okay. Then now the new guidelines tell that you have to give lower dose daily for a longer time. Rather than giving one large dose, which has good chances of causing toxicity, then hypercalcemia and related problems, it is better to stick to a lower dose of vitamin D given daily for 3 months. So if it is below 6 months, we stick to 2000 international units. If it's between 6 months to 1 year, either we stick to 2000 international units or 30,000 international units once in 15 days or 60,000 international units monthly for 3 doses, along with which we'll give calcium syrup. So all vitamin D treatment will be given with calcium and phosphorus treatment so that the absorption of calcium and phosphorus increases and helps in mineralization. Above 1 year, we change it to 3000 international units daily for 3 months. Or we can even give 60,000 international units fortnightly for 3 doses. Again, coming back somewhere around 3 to 6 lakhs of vitamin D. Okay, so that's the catch. So roughly we give between 3 lakh to 6 lakhs of total international units of vitamin D. So this is the treatment of rickets. Now, how do we monitor? The moment we give this treatment, we call them for follow-up after 2 weeks. So after 2 weeks, what test do? We just do a calcium, phosphorus if needed. Otherwise, we just do a radiological screening. So in radiological screening, if we get line of healing, that means a line of mineralization, if it is seen, that means like this. See, if you compare this X-ray where there is spraying, there is cupping, there is flaying. Okay. But when the treatment is given, the cupping comes down, this bright line of healing starts. You can see here there is a bright line of healing. If this starts, that means the treatment is working. That means what we diagnosed and what we thought as the root cause problem, we have addressed it. So that is how you monitor these babies after starting on vitamin D treatment. Okay, now say you have started on treatment. So how do we follow up? One at 15 days to 1 month. Between this time, we call them and get one X-ray done. After that, we call them again after total 3 months of treatment. Like I showed you, vitamin D we'll give for 3 months and then we call them. And then we run some blood picture, that is blood test, that is calcium, phosphorus, ALP and vitamin D again, which will show us near normalization. That means the deficiency that was seen in the first test would have been normalized by the end of 3 months. Now, say at the end of 3 months, there is no change. There has been no improvement, both biochemically, clinically, and our blood radiologically. If that happens, that is when the word refractory rickets is used. So something which did not respond to the standard treatment with vitamin D supplementation and adequate dietary and calcium and phosphorus. If this happens, then it is called as vitamin D refractory rickets, or in simple words, refractory rickets. Now, this is a little complex topic because it depends on uh, multiple things like calcium deficiency, phosphorus deficiency, vitamin D deficiency, and other things. So, roughly, if we remember, these are the 5 important causes of refractory rickets. Not to forget is chronic renal failure, hypophosphatemic rickets, vitamin D deficiency, vitamin D dependent rickets. We'll go across all of this in detail next. Okay. So what is the pathophysiology? You should remember that in all form of rickets, it is defect in mineralization of the bone at the growth plate. Like I already told you, wherever there is, this is the diaphysis, this is your metaphysis, and here is your epiphysis. Now, the chondrocytes increase in their size, okay, and they form a matrix where calcium and phosphorus should deposit and form the bone. Now, when there is no calcium and phosphorus deposition, this chondrocyte thinks that it should work more and ends up producing more growth plate, causing the widening of the wrist, this increased distance between the epiphysis and the metaphysis, and widening of the growth plate. So, this is one common thing that happens in all form of rickets. Why does it happen? Irrespective of whether calcium is low or no, in all form of rickets, there is low serum phosphate. So one common thing, if you remember, whether it is refractory rickets or vitamin D responsive rickets, serum phosphate will be less. Okay. In refractory rickets, the underlying issue is typically renal phosphate wasting or abnormal vitamin D metabolism or the genetic mutations that affect the phosphate and vitamin D handling. Okay. So this is your gross classification of rickets. Now in this class, I want you to understand this table. So when we divide it grossly into calcipenic and phosphopenic rickets, that means predominantly calcium deficiency or predominantly phosphorus deficiency. Here also there will be phosphorus deficiency, but calcium deficiency is more than the phosphorus deficiency. Now, whenever calcium deficiency is there, 90% of the times it is nutritional. That means either intake is less or vitamin D is deficient. Okay, now vitamin D deficiency due to either maternal cause or a nutritional cause or reduced sunlight exposure, all of this. Or if the vitamin D is even taken orally, it can be due to malabsorption, like in celiac disease, pancreatic dysfunction, cholestatic liver disease, all of these, where because you remember vitamin D is a fat soluble vitamin. So for the absorption of vitamin D, you need bile and you need good pancreatic juice also. So if there is any problem with the liver or the pancreatic function, then also you can have vitamin D deficiency. And drugs like anticonvulsants, glucocorticoids, anti-tubercular drugs, all of this go and activate cytochrome P450 enzyme system of the liver, thereby breaking down the vitamin D a little faster. Okay. Then is obesity. What is one more possible cause? The calcium is only deficient. Here vitamin D is deficient. Here calcium is deficient. Now this is what we have discussed in the last class. Now coming to 1, 2 and 3rd category. Now what is non-nutritional calcipenic rickets? That means vitamin D is there, calcium is there, but somehow it is not working. So in that we have vitamin D dependent rickets type 1. So what is the problem here? Here, if you check vitamin D levels in the blood, because we all know that the one which is checked in the blood is 25 hydroxy vitamin D. So 25 hydroxy vitamin D will be normal, but the active form is 125 hydroxy vitamin D, correct? So this conversion happens at renals, that is your liver, correct? It happens at the kidney, that is by the enzyme 1-alpha hydroxylase. So if this conversion doesn't happen, your blood biochemically it will show that the vitamin D is normal, but the active form of vitamin D is not there, because of which vitamin D function doesn't happen. So that is your vitamin D dependent rickets type 1 due to deficiency of 1-alpha hydroxylase. So this is your first inborn error of vitamin D metabolism. The second is, this happens normally. So 25 hydroxyvitamin, 125 hydroxyvitamin D, both are normal in range, but the action happens at vitamin D receptor, correct, which is on the nucleus. Now, if this vitamin D receptor is not functioning, there will be increased levels of these, but the action doesn't happen. Now, what were the actions? Calcium absorption, phosphorus absorption, both at kidneys as well as gut. And when it comes to the bone, it was increased mineralization that had to happen. So all these three actions won't happen, giving rise to a rickets-like picture where we call it as vitamin D dependent rickets type 2. Now, why is it called vitamin D dependent? We'll discuss it later. Okay. So you just remember that non-nutritional calcipenic rickets may vitamin D dependent rickets type 1, where 1-alpha hydroxylase, 1-alpha hydroxylase, vitamin D dependent rickets type 2. Type 2 में क्या हो जाता है? Too much of active vitamin D. So too much of active vitamin D is there, but there is no action. Why? Because the receptor is not functioning. So that is your two types of inborn error of vitamin D metabolism. Then is distal RTA. Now in distal RTA, there are loss of calcium in urine, giving rise to a calcipenic picture, giving rise to a rickets picture again. Okay. So that is your non-nutritional calcipenic rickets. Next, coming to phosphopenic rickets. Now, when it comes to phosphopenic rickets, you should remember that phosphorus metabolism is determined by hormone PTH. We all know this, correct? So what does PTH do? It increases calcium levels in blood, but decreases phosphorus level in blood, causing phosphaturia. That means it causes increased phosphorus excretion in the urine, but at the level of gut, it increases the phosphorus absorption, correct? So this is your PTH functions, but along with PTH, there is something called as FGF23. Now, FGF is fibroblast growth factor 23, which is a humoral mediator. Along with PTH, works on phosphorus ion. So now what does this do? FGF23, if it is more in quantity, it does two things. One is decreases phosphorus by causing phosphorus excretion in urine. The second function it does is it inhibits 1-alpha hydroxylase. So you remember one thing, FGF23 will suppress vitamin D. So FGF23 will suppress vitamin D, active form of vitamin D formation, and causes increased phosphorus excretion in the urine. So depending on whether FGF23 is more or less, you have different causes of phosphate wasting. So if it is FGF23 dependent, then these are the ones which are there. So in this, predominantly you should remember hereditary hypophosphatemic rickets, which can be either X-linked disorder, autosomal dominant, or autosomal recessive. And in acquired, it can be any tumors. There are multiple tumors which produce FGF23 as one of its byproduct or a humoral mediator. So all of them also present with osteomalacia. That's why you see most of the cancer patients having osteomalacia, easily breakable bones, all of that things, correct? And few syndrome like McCune-Albright syndrome and linear nevus sebaceous syndrome. Now this is when FGF23 is more. Now say our FGF23 is normal. That means there is problem with the renal tubules. That means as such the kidney functions are not good, because of which there is phosphate wasting. There is loss of phosphorus that is happening. And the moment there is loss of phosphorus, obviously some amount of calcium is also lost. That stimulates vitamin D production. Vitamin D increases. Along with that, PTH increases to increase calcium. So PTH levels also increase. Because of all this imbalance, again rickets picture come. But the cause is the tubular dysfunction of the kidneys or hereditary hypophosphatemic rickets with hypercalciuria. Each of this we are going to discuss in detail. Okay, so let's go to individual things. Now you should remember that phosphorus is one of the abundantly found ion in the blood. Majority of it is in the bone in the form of hydroxyapatite crystal. Remaining phosphorus is all intracellular in the form of ATP and other phosphate ions, correct? So it basically helps in mineralization of the growth plate by causing apoptosis of the hypertrophic chondrocytes. Like I already told you, once the chondrocytes become big, mineralization should happen and they should die. If this doesn't happen, they keep on growing, giving rise to a widened growth plate, and then the manifestations of rickets, skeletal manifestation of rickets, like we have discussed in the previous class, correct? So next, coming to vitamin D deficiency. Now, grossly, if you want to remember vitamin D deficiencies, causes of rickets, this is the best table you can get to understand the causes of rickets. So here we grossly divide it into vitamin D disorders, calcium deficiency, phosphorus deficiency, or renal causes. Now, most of this is very simple to understand. Vitamin D disorder may either it is nutritional or it is congenital, where mother has not taken much amount of vitamin D, giving rise to a congenital vitamin D deficiency in kid. Secondary vitamin D deficiency, which we'll discuss. Now, secondary to what? Either it is malabsorption. That means either there is celiac disease or chronic inflammatory disease of the gut or some amount of gut disorders like your cystic fibrosis, because of which there is gross malabsorption causing vitamin D malabsorption also. So that can give rise to a rickets picture. Or there is increased degradation of vitamin D, especially in usage of drugs like I told. That is anti-epileptic drugs or your anti-tubercular drugs. Okay, these kind of drugs. Next is decreased liver 25 hydroxylase. So we know that first in skin the vitamin D is activated, then it goes to liver where 25 hydroxylase is there, and then it goes to kidney where 1 alpha hydroxylase is there, then it forms the active form, correct? So now if the kidney is only liver is only not good, then it causes decreased liver 25 hydroxylase, which is very rare because this can only happen when more than 90% of the liver is not functioning. So very rarely in cirrhosis of liver also you can get vitamin D deficiency picture. Other than this, like in the malabsorption, you can even remember cholestasis. The cholestatic picture where there is biliary tract obstruction or pancreatic duct problems. So either bile नहीं आ रहा है या फिर pancreatic juice नहीं आ रहा है. Either of the situation में you will have malabsorption of vitamin D. Okay, so decreased liver 25 hydroxylase, or like we discussed, vitamin D dependent rickets type 1 and type 2, or it can be chronic kidney disease where there will be vitamin D deficiency, correct? When it comes to calcium deficiency, you remember either it is low intake, that means it is a family who never drinks milk or has probably rice as a staple diet, like we see in most of our severe acute malnutrition kids. So either it is low intake where there is a diet issue, or if it is a premature infant where because of prematurity itself the child's calcium, phosphorus and vitamin D status is very less. Remember one thing, 80% of the nutrients like calcium, phosphorus, vitamin D is transferred from mother to the child in the last trimester. So if a child is born premature, then automatically all of these components will be less in the child, giving rise to rickets of prematurity picture, also called as mineral bone disease of newborn. Okay, then calcium deficiency either because of decreased intake or decreased absorption, like in malabsorption syndromes, or primary disease of malabsorption where the calcium ions are probably not working well. Okay, or it can be a dietary inhibitor. So if you give calcium and iron together, then also you can have, sorry, So then also you can have your calcium deficiency. Okay. Then coming to phosphorus deficiency. Now phosphorus deficiency is extremely rare only because of diet intake. That is because irrespective of whether you're a vegetarian, non-vegetarian, all our food sources are very rich in phosphorus. So due to inadequate intake resulting in phosphorus deficiency is extremely rare unless it is a child dealing with anorexia nervosa or a starvation child. So the other possibilities are premature infants and most commonly in adolescents and adults due to excessive usage of aluminum containing antacids. Okay. So these are the only three causes where you can have probably phosphorus deficiency due to intake. Now coming to renal losses. So renal causes are predominant causes which end up having hypophosphatemia, like in X-linked, autosomal dominant, autosomal recessive hypophosphatemic rickets, or any causes which lead to overproduction of fibroblast growth factor 23. Like I already told, what does FGF 23 do? Two functions. Increases phosphorus excretion in the kidney and inhibits 1-alpha hydroxylase. So if you remember this one thing, the entire lecture today will get very simple for you guys. So these are the two main functions of FGF 23 or tumor-induced rickets. All of these syndromes which have end up causing increased FGF 23, or it can be tubular dysfunctions like in Fanconi syndrome, Dent disease, renal tubular acidosis, where predominantly it is the proximal convoluted tubule problem or rarely distal convoluted tubule problems, because these are the places where ions get reabsorbed. Okay. So this is the simplest way you can write causes of rickets. You divide it into vitamin D deficiency, calcium deficiency, phosphorus deficiency, and renal causes. And then on, keep talking about whether it is intake problem, increased breakdown that is happening, or decreased absorption because of malabsorption problem that is happening. Correct? So coming back to in detailed discussion about secondary vitamin D deficiency. Like I already told, either it is decreased intake, like as in less exposure to sun, always wearing niqab, okay, these kind of things, or it is inadequate absorption, like in liver and GI disease, like cholestasis, cystic fibrosis, pancreatic dysfunction, celiac disease, Crohn disease, in even short bowel syndromes. If there is, the short bowel resection that has happened because of some issue in the gut, or even lymphangiectasia. So these also can cause inadequate absorption of vitamin D, or increased degradation due to activation of cytochrome P450 enzymes like in ATT drugs or ATTs, antitubercular drugs, or anti-epileptic drugs. See, per se liver disease causing decreased hydroxylation is very rare. That's what I told you. More than 90% of the liver parenchyma, if it is gone, only then you have the liver parenchymal induced vitamin D deficiency. Correct? So next, going to vitamin D dependent rickets type 1. So vitamin D dependent rickets type 1. So this is autosomal recessive. So it is autosomal recessive 1 for 1, that is 1-alpha hydroxylase deficiency. So now where is this enzyme? This is in kidney. So that means there is only production of 25 hydroxy vitamin D, because of will get rickets feature but normal vitamin D. Why? Because the blood test that we do is to detect this, not the active form of vitamin D. So because active form of vitamin D is not there, it gives rise to vitamin D functions like increased calcium and phosphorus absorption is hampered. Correct? So now this will give rise to a hypocalcemia picture. Hypocalcemia will stimulate what? It will stimulate PTH production. That is parathyroid hormone production. Once parathyroid hormone is high, what it will do? It will increase calcium, but it will try to decrease phosphorus by causing phosphaturia. So when you see biochemical examination, when you see a child with rickets who has not responded to your treatment for 3 months, you do the blood test again, calcium would have been normalized, phosphorus would be less, vitamin D would be normal. So that is when you have to do active form of vitamin D testing, where it will be less. Active form of vitamin D will be less. Along with that, it can even have renal tubular dysfunction. Now this is plus minus. It can be there, it may not be there. So such kind of kids will have reduced concentration of 125 hydroxy vitamin D, but normal vitamin D, and phosphorus will always be low. Calcium would have been normalized. PTH would be high. So if we get this kind of a picture, then we have vitamin D dependent rickets type 1. Now don't ask me clinical features. Clinical features is exactly what we have discussed completely in detail in the previous class. So how do we treat this? We give active form. Now active form of vitamin D is not formed. So we'll give active form of vitamin D, that is calcitriol. Along with vitamin D, we will give calcium and phosphorus supplements also, so that mineralization takes care. Now here we should be careful with the monitoring. So what do we do in the monitoring? The best way to monitor is ALP. So if your ALP is monitored well, then if ALP gets normalized, now alkaline phosphatase is released from osteoclast. From the bone breakdown, it gets released. So if alkaline phosphatase, which is generally high in rickets, it is generally high because body tries to make serum calcium normal by causing breakdown of the bone calcium. So the moment you start treatment, your ALP starts reducing or it becomes normal. So that is the best way you can monitor this vitamin D dependent rickets. Okay. So next, coming to vitamin D dependent rickets type 2. So the best way to remember is 2 for too much. So too much of active form of vitamin D is there. So why it is too much? Because receptor is not working. The moment receptor is not working, the previous substrate starts increasing to see if the increased concentration has some effect on the receptor. So it is the problem with vitamin D receptor which causes rickets picture here, because of which the active form of vitamin D will be very high. Okay, so active form of vitamin D will be very high. It is also autosomal recessive, presents predominantly in infancy, but can be missed, causing presentation in the adolescent phase. Now, those who present in adolescent phase, that means they have a less severe disease. Meaning what? There is partial functioning of vitamin D receptor, not the complete non-function. But if a child is having alopecia, that is 50 to 70% of vitamin D dependent rickets type 2 have alopecia. So if they have alopecia, it indirectly means that it is a completely non-functioning vitamin D receptor. That means it is a severe form of the disease and mostly well present within 2 years of life. So below 2 years of life, if you see alopecia, then you should keep this in your differential diagnosis list. Okay, now what is the treatment? Actually speaking, vitamin D levels is already very high. So there is nothing that you can do and go and act on the receptors. So this is one of the most difficult rickets to treat. Plus, because rickets treatment is prolonged over time, by the time you are giving a proper treatment, you would have done all trials, the child would have got a fixed deformity, like a lower limb deformity, sometimes even valgus deformity or windswept deformity would have already set in, thereby giving rise to a picture where we have to take help from our orthopedic friends to correct the deformities. Okay. So what is the treatment? High doses of vitamin D. Either you give 25D or 125D. Now 25D is the one which is generally available in our markets. Correct. So over the counter what we get is 25 hydroxy D. This is a little pricey. So either of this you can give, because problem of conversion to active vitamin D is not there. But what will this high doses do? It will probably act a little on partially functioning receptor. So you always give a trial of high doses of vitamin D along with high doses of calcium. If this doesn't help, in few patients, IV calcium, directly giving IV calcium maybe weekly once or twice also has helped. But overall, this is one of the most difficult type of rickets to be treated. Next, coming to CKD, that is chronic kidney disease. Now, in chronic kidney disease, what is the problem? We know that kidney has 1-alpha hydroxylase. So obviously, if chronic kidney disease is there, the 1-alpha hydroxylase levels also will be less. Thereby, active form of vitamin D will be low. Okay, so plus, because active form of vitamin D will be low, automatically calcium will be low, automatically phosphorus also will be low. But there is a catch here. In chronic kidney disease, what happens? The excretion of phosphorus is affected because the tubular functions are greatly impaired. Although body is trying to excrete phosphorus by increasing the PTH production, it is not getting excreted because there is problem with the tubules. So the excretion by the kidney is not happening. So that's how phosphorus level goes up. Okay, but body to sensing this, what will PTH do? It will increase its concentration again, thinking that I will push away this phosphorus now. So the concentration of PTH also will be very high. Vitamin D will be low, calcium will be low, but phosphorus will be high. So anytime in a rickets child, if you find that phosphorus is high, unless proved otherwise, it will be a chronic kidney disease child. So what is the treatment that we give? We give active form. Obviously, active form of vitamin D is not produced. So you give active form of vitamin D. Now, what is the use of giving active form of vitamin D? One thing is it will help in calcium and phosphorus absorption at gut. It will help in calcium and phosphorus deposition in the bone. Plus, because calcitriol active form of vitamin D also suppresses PTH, it reduces the PTH concentration. PTH is parathyroid hormone concentration, thereby trying to normalize the phosphorus also. Okay. Then you have to treat the hyperphosphatemia because it can be life-threatening. We give phosphate binders, oral or anal this thing. We give phosphate binders by which we try to reduce the phosphorus concentration in chronic kidney disease. Okay. Next, coming to the calcium section. So I showed you the initial classification. Now we are moving on to the calcium section. So if calcium deficiency is there, either it is intake deficiency. So like in severe acute malnutrition child, a family where the weaning is being started very early, a family where there are no dairy food intake. So in those kind of picture, we have intake deficiency or malabsorption, like in malabsorption syndrome, celiac disease, cystic fibrosis, all of these. Okay, so these are the most common causes of calcium deficiency. So that is why you see it presents also, calcium deficiency induced rickets presents also between 15 to 25 months, because that is the time when the food intake matters a lot. So after 1 year, if the child is not been given any dairy products, there is gross calcium deficiency in the food, then this kind of rickets comes up. So generally it coexists with vitamin D deficiency. Treatment is improving the diet. So if you see a OPD child where you know by the diet history, it looks more like a calcium deficiency in the diet, you just improve the diet. And this has been almost proven in Kenya also, where like how we have done food and meal programs in the schools, they have done school-based milk programs where they gave milk to all the kids and found that calcium deficiency was improving. Okay, so this is the calcium deficiency. Next, coming to phosphorus deficiency. Now, like I told, phosphorus deficiency only by reduced intake is very rare. That can happen only if the child is starving or the child probably in a state has anorexia nervosa. Okay, that's the only time where you get inadequate intake induced phosphorus deficiency, because all our food have phosphorus in it as its content. It is widely available in all the foods. Okay, so other possibility of having phosphorus deficiency is by malabsorption, like classically in aluminum containing antacids, classically seen more in adults and adolescents, okay, who have gastritis and end up taking this aluminum containing antacid for a long time, thereby causing phosphorus deficiency and rickets and osteomalacia. Okay, so if phosphorus deficiency has rickets, then you have to suspect vitamin D and calcium malabsorption, which is coexisting probably. It won't be a isolated phosphorus deficiency. Okay, and we have to remember this word, that is FGF23, fibroblast growth factor 23, which causes reduced phosphorus levels and reduced vitamin D levels by inhibiting 1-alpha hydroxylase. Okay, now next coming to different forms of hypophosphatemic rickets. Let's start with X-linked hypophosphatemic rickets. Like the name tells, it is X-linked dominant. So that means females will be recessive carrier, females will be carriers, and males will have symptoms, correct? So what is the problem here? There is mutation in the PHEX gene. Now you remember this PHEX, PH is for phosphorus. So phosphorus regulating gene, which has similarity with the endopeptidases on X chromosome. So this is the gene which is affected. Now what happens if this gene is affected? There is increased levels of FGF23. And we know FGF23 decreases active form of vitamin D, that is 125 hydroxy vitamin D, and it decreases phosphorus levels, both of which will give rise to our skeletal symptoms. Okay, but there is a catch here. In this X-linked hypophosphatemic rickets, it presents a little late, not during the 1 year or 2 year that we classically see in a nutritional rickets. It presents around 5 to 10 years of age, more so picked up in adolescents, where they predominantly present with lower limb abnormalities. They have bowing of legs or genuvalgum, those kind of things, without widening of the wrist or the head circumference changes that we have discussed in the last class. Along with that, they'll have history of delayed dentition and repeated tooth abscesses. So repeated tooth abscess, enamel problems, all of this should caution you guys towards X-linked hypophosphatemic rickets. Okay. Then we have poor growth, or the child might isolatedly come to us with short stature. The only complaint can be the child is not having increasing in height. So in such situations, what you have to do is you should examine the mother. Because we know that it is X-linked dominant. If mother has bowing of legs, it is almost a it is almost a clinical diagnosis that probably this is a X-linked hypophosphatemic rickets. Okay. So how will be the investigations? Obviously, you have low phosphorus levels. Why? Because there is increased excretion of phosphorus, which can be detected by TMP-GFR. So this is a test which is done to find out how much percentage of phosphorus is excreted in urine. Okay, so you just remember it as high TMP. Okay, high TMP-GFR. High TMP-GFR. Okay. Then, because active form of vitamin D is not found, obviously your vitamin D levels also will be low, your ALP levels will be high, and PTH and calcium levels will be normal in X-linked hypophosphatemic rickets. And the treatment will be, because there is phosphorus deficiency, you will give phosphorus, and active form of vitamin D is less, so you will give calcitriol. So overall, this is a good prognosis because it responds very well to our treatment. Okay, next is your autosomal dominant hypophosphatemic rickets. So what should you remember? Just two things you remember here. Here the problem is in the gene encoding FGF23. We also know the function of this. So it will present same as X-linked hypophosphatemic rickets because the end product is same. There is increase in FGF23. So clinical features, investigations, treatment, all of it will be same. And this is a autosomal dominant rickets. So you can also find the family history of bowing of legs and family history of short stature in this case. Next, coming to autosomal recessive hypophosphatemic rickets, which in turn has type 1 and type 2 again. So in type 1 hypophosphatemic rickets, you have mutation in the genes encoding dentin matrix protein. So basically it is what? It is a kind of matrix protein required for the skeleton of the, required for the bone formation. So whenever DMP is involved, it is type 1. In type 2, it is mutation in ENPP1. You need not remember these words as such, but you should remember that in type 2, there is generalized arterial calcification of infancy. So we all know that calcification of arteries, atherosclerosis is all after certain age. But if we have a child who presents very early with arterial calcification, so when you palpate the peripheral pulses, you feel it to be a string-like pulse, or you feel the thickening of the arterial walls, that is when you should keep autosomal recessive hypophosphatemic rickets as the differential diagnosis. So all these three are basically can be diagnosed by genetics. So if nutritionally non-responding, that is refractory rickets, come to you and we are having a hypophosphatemia picture with vitamin D low levels with high PTH levels, maybe we'll do a active vitamin D levels, that is 125 hydroxy vitamin D, And if that is also low, then our next investigation probably should be whole exome sequencing, that is genetic testing, to find out which mutation is involved, to find out the exact cause of rickets. Okay, now coming to this separate entity, that is hereditary hypophosphatemic rickets. But you saw in the previous slide, our calcium was either normal or it will be low. But here, although it is hypophosphatemia picture, calcium, instead of being normal, it is high. So high that it causes hypercalciuria. So why is this happening? Because here, this is also autosomal recessive. Here there is mutation in the gene for sodium and phosphate co-transporter in proximal convoluted tubule. So what do we understand? This is not FGF2/3 dependent. It is not because of fibroblast growth factor dependency. So here it is basically the tubule problems. So either your proximal convoluted tubule or distal convoluted tubule problems, then you call it as FGF3 independent, correct? So fibroblast growth factor 23 independent. So here the problem is in the proximal convoluted tubule, where sodium and phosphate co-transporter is mutated, because of which there is sodium loss also, there is phosphate loss also in the urine. Now, our concern is phosphate. It causes hypophosphatemia. Now, we all know that hypophosphatemia will increase vitamin D production in an attempt that the body will normalize the phosphorus levels. But along with this, this will cause hypercalcemia causing calciuria. So, this is what happens in a hereditary hypophosphatemic rickets with hypercalciuria, which is a separate entity. Giving rise to, again, clinical features are predominantly lower limb symptoms, along with which they can have muscle weakness and bone pain. Because hypercalciuria is there, then you can have kidney stones also. So if you find multiple kidney stones without any reason, we even need to work up for this entity. So what is the treatment? We give just oral phosphorus. So the moment oral phosphorus is continuously supplemented to the person, the vitamin D levels will normalize, thereby normalizing the calciuria. So this is one of the excellent prognosis in our vitamin D dependent rickets, correct? So it is one of the excellent prognosis in refractory rickets. Now these are the other conditions where there is overproduction of FGF23, like already discussed. We already discussed in the flow chart. So either any tumors, syndromes like McCune-Albright syndrome, epidermal nevus syndrome, sometimes even neurofibromatosis can give rise to a rickets picture because of FGF23. When it is FGF23 independent picture, it is proximal convoluted tubule problem or distal convoluted tubule problem. Proximal convoluted tubule problem, most commonly it is Fanconi syndrome, or your hypophosphatemic rickets with hypercalciuria, or it can be distal convoluted tubule problem, where like in dent disease, where it is X-linked with chloride channel problem in the kidney. Now, details of this is not really required here. We will discuss this once we are starting our renal systems. Okay, so just remember the names for now. So this is how you diagnose these hypophosphatemic, vitamin D dependent rickets and nutritional rickets. One thing in common is phosphate is low in all except in chronic kidney disease. Okay, this 25 hydroxy vitamin D is generally low in nutritional rickets. In vitamin D dependent rickets, it can be low or high, as in vitamin D dependent rickets type 2, where it can be high, and vitamin D dependent rickets type 1, where it can be normal, correct? Parathyroid hormone can be normal in hypophosphatemic rickets, okay, because hypophosphatemia is there, PTH is probably not stimulated, because parathyroid hormone wants low phosphorus and high calcium levels, correct? So in others, it will generally be high in an attempt to normalize your calcium levels. So corrected calcium can be normal, or it can be very low in vitamin D dependent rickets, because obviously vitamin D function is not there, correct? Alkaline phosphatase is high in all. Why? Because the compensation is coming from the bone. And 125 hydroxy vitamin D is very high in type 2 or low. Okay, so rough picture to remember. So what is one thing that you have to remember? All refractory rickets generally affect lower limbs more than the upper limbs. And like you can see, more than uniformly affecting the bone, it affects one of the condyles. So either medial or lateral condyles are affected more. So you can see predominantly affects medial condyle. Coarse trabeculations is there. Thickened cortex is also there. And not classically all features of cupping splaying will be there. But you can see that there is bone mineralization defect causing splaying and some amount of mild cupping only on one condyle. So if you have this non-uniform distribution of radiological features, then also you should think in terms of refractory rickets. Okay. So this is the summary of the entire refractory rickets discussion. You can go through this. If you have any doubts, we can always discuss this in detail again. So this is just a summary of the treatment of refractory rickets, that is hypophosphatemic rickets. We give high amount of oral phosphorus and active form of vitamin D. In vitamin D dependent rickets type 1, we give active form of vitamin D because that is not produced. It is 1-alpha hydroxylase deficiency. In the vitamin D dependent type rickets type 2, it is too much of vitamin D we have, but still the treatment is very high doses of calcitriol and IV calcium. So one of the most difficult to treat is this. Okay. So this was just the summary. Yeah. So that's it with the refractory rickets. Now this is a little confusing, so you should make sure that you remember it in terms of this table. So how do we deal with vitamin D refractory rickets or vitamin D dependent rickets? You divide them into 4 broad categories: vitamin D deficiency, calcium deficiency, phosphorus deficiency, and renal causes. Vitamin D, you tell reduced intake, reduced absorption, or increased breakdown. Calcium also reduced intake, reduced absorption. Phosphorus also reduced intake, reduced absorption. Renal losses, it is either FGF23 dependent or FGF23 independent. So FGF23 independent are all. So FGF23 independent are all. So FGF23 independent are all tubular dysfunction. So either it is problem with the proximal tubule. So either it is problem with the proximal tubular dysfunction or your distal tubular dysfunction. Correct? So if you remember these two tables, then it should be sorted. You should just remember these two tables for understanding refractory rickets. I think we'll stop the class here. Any doubts? If you have any doubts, you can always message me on Instagram or my WhatsApp number. To go through these videos for complete understanding of vitamin D deficiency and rickets. I hope I am clear, and I think we can stop it here. Next class we'll start with, we'll just take a small session on vitamin D toxicity followed by vitamin A deficiency and toxicity. So that will be our next class. Okay. We can take up the questions if any. All right, so I'll stop it here. Yes, done. Thank you.